Greetings again, ladies and gentlemen. Welcome to case study number 41. This will be a neonate with bilious vomiting. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right-hand corner. I very much appreciate all the contributions I can get to help offset the cost of these videos, and I thank all those of you who have already stepped up to donate. I very much appreciate it. Okay, we got a 2-week-old white male neonate who's being brought into the ED by his mom due to vomiting and inconsolable crying. The crying began this afternoon, and an hour later he had one episode of vomiting, which was dark green in color. So we got bilious vomiting here. This has never happened before, and baby has been otherwise healthy. His last dirty diaper was last night. Prenatal, birth, and postnatal history were uncomplicated. He was born at term. The patient has no significant past medical history, no siblings, is on no medications. He's in the 20th percentile for weight and 15th percentile for length, so a little small. He's up to date on all vaccinations. Vitals, blood pressure 90/61. That sounds low, but actually for a neonate, that is high. Heart rate 172, that is high. Respirations 54, temperature 98.8, and setting 89% on room air, so that is low. All right, so what are we going to do for physical exam? Well, we're actually going to be fairly focused here because this is a problematic presentation for a variety of reasons that we're going to go into. So he is fussy, poor capillary refill, not a surprise there with the vomiting. Cleared auscultation, no murmur. Abdomen, this is going to be an important part of your physical exam because we're talking about GI symptoms here. There's crying on palpation, indicating some abdominal pain. The abdomen, however, is flat, so it's non-distended. There's no guarding, and bowel sounds are not appreciated. Now, anytime you have GI complaints, you need to go ahead and do a rectal exam. And we find normal sphincter tone, but a small amount of dark stool that is occult positive. So we've got some GI bleeding. All right, so we got GI bleeding, a little bit of dehydration possibly going on here, and bilious vomiting. So something going on probably in the small intestine. Our differential is going to be malrotation with volvulus, very common at this age. Necrotizing enterocolitis tends to be more in premature babies. This baby was born at term. Duodenal atresia, also fairly common, and intussusception. Okay, so our initial orders are going to be to rehydrate and stabilize this patient. He was hypertensive, but that was probably due to the pain. Remember, poor capillary refill is a sign of dehydration, and so we want to replenish fluids with normal saline. You will not be expected to know the rate or anything like that for your steps. We're going to give supplemental oxygen because he wasn't satting well, and we're going to get arterial blood gases, and that is due to a variety of reasons, but mostly because this patient was unstable. So we do want to get arterial blood gases. We're going to get routine labs, BMP, CBC, and then we're going to get an abdominal x-ray and an abdominal ultrasound. And I will go into why that is. Some people think we only need to do one or the other, but I think it's probably best to do both here. Okay, and what do we find? The ABG showed a low PaCO2, but a low bicarb. So what do we have here? We have a metabolic acidosis. And that could be a sign of tissue hypoxia. CBC showed an elevated white count, a slightly low hemoglobin, and a slightly low hematocrit. Now, you might look at 13 and be like, well, that looks normal. Not in a neonate. Their hemoglobin is a little bit higher than for adults. The abdominal x-ray shows a double bubble sign, but no intramural gas or evidence of perforation. That makes necrotizing enterocolitis less likely. The abdominal ultrasound showed a whirlpool sign. All right, so what does this mean? It means that the most likely diagnosis is malrotation with volvulus. The double bubble sign pretty much narrowed it down to volvulus and duodenal atresia. But duodenal atresia typically does not cause pain. So midgut volvulus which is usually due to malrotation, is going to be our most likely diagnosis here. So we're going to refer this patient off to surgery, and because this is typically an emergent surgery, we need to get all our surgical labs. So we consult pediatric surgery, get NG tube suction to decompress, and then of course NPO, maintenance fluids, coagulation, and type and cross match, as we always do before surgery. Another thing we always do before surgery is administer antibiotics. However, in this case, because we're worried about the possibility of perforation, we need to administer broad spectrum antibiotics, not just your typical Keflex that you might give before a routine surgery like an appendectomy or something. So we give broad spectrum antibiotics. Ampgent is fine for this. And then an upper GI series may or may not be done. You should know that that's the gold standard, but with that abdominal ultrasound, the pediatric surgeon may just go ahead with laparoscopic surgery here. Okay, so this is what you would see on that upper GI series if you were to get it. Notice here that you've got a lot of filling, but it's mostly on kind of the right side. So again, you kind of see that here where it's more on the right, not so much on the left. You also get this corkscrewing sign, which you kind of see right here. And then you kind of see a little bit right here. And that is classic for midgut volvulus and for malrotation. Okay, so this is a cartoon of what it looks like. Notice that this is normal here. Notice that the duodenum crosses the midline, whereas with malrotation, not so much. All right, so that upper GI showed a corkscrew sign. Intestinal malrotation is a failure of normal embryologic rotation as the gut develops outside the abdominal cavity and then returns to the abdominal cavity. This results in an abnormal configuration. So the big problem with this is that because you have no fixation to the retroperitoneum, the bowel is more likely to twist on its mesentery, and the result of that then is a volvulus. About 50% of patients with malrotation will present within the first month of life with a volvulus. The problem is that you don't know if there's malrotation until you get a presentation. The symptoms of volvulus are bilious vomiting and abdominal pain, and then progressively, as the bowel dies from ischemia, you can get distension, guarding, sepsis, and ultimately death. So this is an emergency. Now, bilious vomiting in a neonate or an infant is a potential midgut volvulus with that is until proven otherwise. So you've got bilious vomiting. The number one thing on your differential always needs to be malrotation and volvulus. The best initial step in management is, of course, to stabilize the patient with fluids and oxygen. The best initial diagnostic test is an abdominal ultrasound, and sometimes the pediatric surgeon will go based on that alone. However, the most accurate test is an upper GI contrast series. So remember the difference between the first step in management and the first diagnostic test. Sometimes you need to manage the patient before you start getting your workup, and that's what we did in this patient. The treatment is decompression with NG tube, NPO. Refer the patient to pediatric surgery for an emergent correction, also known as a LAD procedure. Our common differentials. Necrotizing enterocolitis. This tends to be in premature neonates, usually delivered less than 30 weeks gestation. Presents typically within the first month, only about 25% present after that. But they have a similar presentation. They get the bilious vomiting. They can have some distension. They can have some blood in the stool. If you were to get an abdominal x-ray, usually you would see pneumatosis intestinalis, which is intraluminal air. Duodenal atresia tends to just be isolated vomiting, bilious vomiting. Pain is pretty rare, so these children will come in looking just fine, and the mom's concerned because they're puking up green stuff, but otherwise baby looks okay. Get an abdominal x-ray, you see the double bubble sign, just like what we saw in the midgut volvulus. Intussusception usually presents later, 2 months to 6 years. It's a pretty standard period. You'll have bilious vomiting, maybe not. The big thing that separates this is colicky abdominal pain, whereas neck and midgut volvulus are more constant. The abdominal ultrasound will show the bullseye sign. We had another case study where we went over this, so you can go back and see if you can find it. So notice here, this is why we get the abdominal x-ray and the abdominal ultrasound, because it will take care of all of these. This is something you can look at and print it out if you want. So to recap, malrotation is a failure of rotation as the gut returns to the abdominal cavity. So it's something that happens prenatally. This lack of fixation and the LAD bands can lead to an increased risk of volvulus and obstruction, respectively. The symptoms of volvulus are bilious vomiting and abdominal pain, which can progress to sepsis if you get perforation or ischemia. For diagnosis, you can get an abdominal x-ray to check for perforation and rule out neck, but the best initial diagnostic test is the abdominal ultrasound, and the gold standard for diagnosing Malro is the upper GI contrast series, which would show a corkscrew or a bird beak sign. Remember to stabilize first, refer to pediatric surgery, get pre-op labs, and get broad-spectrum antibiotics like Amgen. The complications include perforation and bowel necrosis. But remember that this is an emergency, so you need to be very, very, very efficient when you're working these cases up on CCS.